Right, today we are going to talk about the clinical correlations associated with the third cranial nerve. Already in the last lecture we discussed origin of third cranial nerve, course of the fibers of the third cranial nerve, and eventually distribution of fibers, how they innervate the extraocular and intraocular muscles, right? Now we will talk about the clinical applications. So let's start the third cranial nerve from the beginning. That will start that third cranial nerve from the midbrain, and what could be the clinical problems, right? Then third cranial nerve in the arachnoid space, then what clinical problems can be there, then third cranial nerve passing through the, yes, cavernous sinus and orbit, and what are the clinical problems. But before I really go into that detail, I would love to tell you that when someone has damage to the third cranial nerve, what is the clinical presentation? What are the clinical presentation, right? So we'll start with that first. First I will tell you that what happens to the eyeball, right, when third cranial nerve is damaged, when it is damaged. First we'll talk about that, and then we will see what are the causes of that damage. First we are going to talk about the result of the damage, that we just imagine if third cranial nerve is damaged, what happens to eyeball, right? I will discuss first that thing. Then later on I will discuss that what are the causes of damage to third nerve, or what are the causes of third nerve or oculomotor palsy, right? So let's start with the damage. Now basically, as we remember from the previous lecture, third cranial nerve or oculomotor nerve has two types of fibers. Mainly there are somatomotor fibers and there are visceromotor fibers. Visceromotor fibers are basically parasympathetic fibers, right? So let's start with it. Number one, that the fibers which are passing through the third cranial nerve, number one are somatomotor fibers, right? These are of course also called general somatic efferents, right? So we have to talk about when these fibers are damaged, what happens to the eyeball. And secondly, we need to talk about that the second group of fibers which are in the third oculomotor nerve, they are parasympathetic fibers. We also call it visceromotor fibers, and because visceromotor fibers, here these fibers are parasympathetic fibers, so we can also call them that they are parasympathetic fibers. You remember they are coming from which nucleus? Yes, very good, Adinger-Westphal nucleus. And we can also call them general visceral efferents, right? Now, as we know, somatomotor fibers supply to, I will make the structure of the eye here, right? Let's, in this structure I am drawing the right eye, okay? So let's suppose this is your beautiful eyeball, right? Here is, okay. Now, the muscle which is going from here, what is that? Superior rectus, right? And here is which one? Inferior rectus. And here is medial rectus. And of course here is lateral rectus. So medial rectus, lateral rectus, superior rectus and inferior rectus. Then there are oblique, right? You know that superior oblique will come from that direction, and then it will be, yes, superior oblique. Superior oblique and inferior oblique is coming over here. Inferior. So this is your superior oblique, and here it is inferior oblique. Now, as you know, third cranial nerve supply all the extraocular muscles except two, right? Number one, it does not apply the lateral rectus. You know lateral rectus is LR6. That is lateral rectus supplied by the abducent nerve or sixth cranial nerve. And superior oblique, right, here is a pulley around that it is going, it is SO4, superior oblique by the fourth cranial nerve, or we call it trochlear nerve, right? Now remaining all muscles are supplied by the What is this? Oculomotor. Along with that, there is another muscle which is, yes, levator palpebri superioris. This is also supplied by third cranial nerve. So we can say third cranial nerve supply the medial rectus, right? Also supply the inferior rectus and also supply the inferior oblique. These three are supplied by the inferior branch, right? And superior branch is supplying the, what is that? Levator palpebri superioris, and also supplying the superior rectus. Now, if third cranial nerve somatomotor fibers are damaged, now which muscles will be damaged? Of course, it's very easy to understand. Medial rectus will be damaged. You cannot pull the eye medially. You cannot adduct the eye. Superior rectus is damaged, so you cannot elevate the eyeball. Inferior rectus is damaged and you cannot depress the eyeball. So the main problem in the movement of the eyeball is you cannot elevate, you cannot depress, you cannot adduct. Is that right? And of course, inferior oblique is also damaged. Inferior oblique, right? It is like that. Okay. Let's suppose this is my eyeball. This is my eyeball. Inferior oblique come from here and attach on the back. This is the front of the eyeball. Here is the front. This is the back. Is that right? And inferior oblique from the orbit take origin and come and attach here. Inferior oblique, when it contract, it elevates, right? So actually inferior oblique is also damaged. So naturally, again, failure of elevation of the eyeball. So failure of elevation of eyeball is due to failure of superior rectus and inferior oblique. Medial rectus lead to failure of adduction and inferior rectus lead to failure of depression. But there is something which is very important. And what about levator palpebri superioris? When, yes, levator palpebri superioris elevates the upper lid, and when this is paralyzed or not functional, there is drooping of the upper lid. There is drooping of the upper lid, and that drooping of the upper lid will lead to a condition called Tosis, right? We call that condition Tosis, right? But there is something very important to understand, that while oculomotor nerve somatomotor fibers fail, there are two muscles which are still functional. Number one is SO4. This is, very happy. And number two, LR6. This is also very happy, because lateral rectus is also working and superior oblique is also working. Is that right? Now I will just show you superior oblique with little more clarity. Let's suppose here is your eyeball, right? And oh my god, this is too prominent. It's not like cornea. Oh, it is again having some trouble. Anyway, no problem. Let's concentrate on superior oblique. Superior oblique take origin from here, and here it is. There is a trochlea or a pulley here, right? Around that it moves. Now, when superior oblique contracts, if it is functional, I told you SO4, that is trochlear nerve is functional. If there is isolated lesion of third cranial nerve, trochlear nerve is functional, and if trochlear nerve is working, that will lead to action of superior oblique. When superior oblique muscle contract, actually this pulls backward, because this end is the fixed end. When it pulls backward, this part or aponeurosis, this is pulled forward and upward. So when this posterior part where it is attached, when superior oblique will contract, it will contract in this direction, and of course this will pull into that direction. Now when this is pulling into that direction, eyeball will rotate, it will move downward. So actually superior oblique is a depressor. Superior oblique is a depressor. Is that clear? Now we can see that with third cranial nerve oculomotor fibers, which fiber? Somatomotor fiber damage, superior oblique is still functional and lateral rectus is still functional. Lateral rectus will pull the eyeball laterally. So what will happen in this patient? Eyeball will be pulled pathologically in which direction? Lateral direction, externally. Is that right? Because the medial rectus is paralyzed. So lateral rectus is still functional, and due to unopposed action of lateral rectus normally, if we are looking forward, what really happens, lateral rectus and medial rectus, they are having equal tone and equal strength, so they are balancing. But when medial rectus is paralyzed, lateral rectus has unopposed action, and that will pull the eyeball laterally, number one thing. Secondly, superior oblique will be also having unopposed action because other muscles are paralyzed, right? And because elevators are paralyzed. So superior oblique, because it is functional due to stone, it will push the eyeball downward. So what really happens in this patient with third cranial nerve palsy, when somatomotor fibers fail, that will lead to the eyeball which is pulled by the, what is this, lateral rectus laterally, and also, okay, this is the eyeball, this is right eyeball, lateral rectus is still working, so it turn laterally, and superior oblique is still functional and turn downward. So what will happen, eyeball will be looking down and out. Eyeball will be looking down and out, and with that, levator palpebris superioris, which was supplying the superior, right, this is the tarsal plate, and here is your muscle, tarsal muscle. Now, so levator palpebris superioris, when it is paralyzed, it cannot pull the upper lid upward, it cannot lift the upper lid properly. So what will happen, upper eyelid will droop down, and it will partially overcover the eyeball, and this is called ptosis. Please don't call it ptosis. P is silent, right? I don't know why P is silent. Maybe it's for some vulgar thing, or I don't know, really don't know, right? But anyway, they are keeping the P silent, so they call it ptosis, right? Now, so this is what is happening to the eyeball, that eyeball looks down due to superior oblique action and out due to abducent action, and with that there is partial or complete ptosis depending upon degree of failure of levator palpebris superioris. Now, if we look to the patient, if a patient comes to you and who is having failure of somatomotor fibers, right, because extraocular muscles fail, this kind of failure is called external ophthalmoplegia. Plegia means weakness or failure of the muscles, right? So this is external muscles of the eyeball, because in the eyeball there are internal muscles also. In the eyeball there is internal muscle like sphincter pupillae, dilator pupillae, or ciliaris. We are not talking about that. We were talking about when somatomotor fibers fail, when general somatic efferent fibers fail, then extraocular muscles, all of them fail except lateral rectus and superior oblique, right? And this kind of situation is called external ophthalmoplegia, right? Now, let's suppose first I make the two eyeballs. I'm not very good at making beautiful eyes, but anyway, let's suppose this is the normal eye, left side, right? So now normally what happens, that upper lid is partially covering the upper part of cornea. This is normal, but in this eye I will show that there is failure of what? Somatomotor fibers. If somatomotor fibers fail, then eye will be looking down and out, right? And with dilated pupil, which I will explain later. This is looking down and out, and actually if you look at this is also now you see that upper eyelid is pathologically covering the eyeball, and eyeball is looking down and out with dilated pupil, right? And sometimes this ptosis is so much that it covers most of the pupil. Is that right? So ptosis may be partial or complete depending upon how dense damage is there, right? So down and out with partial ptosis, right? I remember one lady that I asked her that she was having a little bit problem with the third nerve, and of course her one right eye was down and out with partial ptosis. But she was very jolly. I say, how is your life? She was young, just 23 years old, and she told me that in the beginning she was depressed, but now she is happy. I said, for what? She said, you know, women will do anything to get attraction of men. And every man thinks I'm partially winking like this. And I'm getting a lot of attention. Right? And later on I can explain, I choose the man, another man I tell I have third nerve palsy. I don't know how much it was true, but she was at least taking some positive attitude towards this thing. So I was looking down and out with partial ptosis, always winking. Is that right? This is one thing. Secondly, this is called external ophthalmoplegia. Any question up to this? There's no question? Clear. Now we come to another thing. If visceromotor fibers fail, then what happens? If parasympathetic fibers fail, right? So for that purpose, I will again draw the eyeball and try to make it more clear. Yes, I will make the lens here, and here is constrictor pupillae muscle, right? This is the constrictor pupillae muscle, and which muscle is here? Yes? No, this is dilator pupillae. What is it? Dilator pupillae, which pulls into that direction. Okay? This is dilator pupillae. And pulls dilate, it opens the pupil. Constrictor pupillae constrict the pupil. Is that clear? And then ciliarus, let me make the ciliarus more clearly. It is here and okay, and it is here. I will exactly tell you how the ciliarus work and what will happen to actually ciliarus has its interior end fixed. This part is fixed and its posterior end is mobile. When it contracts in this direction, right? Or when it is contracting, actually it is contracting into this direction. You get it? When ciliarus relax, this posterior end becomes more posterior, and when it contracts, this end moves forward and inward. So when it is going to contract, it will move forward and inward. Now here is your lens, and these are zonular ligaments which are attached with the posterior end. Now listen one thing, when this muscle will contract, this end, posterior end, my thumb, this will move forward and inward, and when it will also move inward, so contracted muscle will look like this. Right, and this point has reached here, and this point has reached here. Now let's suppose this is A dash, and after the contraction, new position, this is B and B dash. Now difference between A and A dash, when muscle is relaxed, this distance is more. So these elastic, what are these? Ligaments, suspensory ligaments. When muscle is relaxed, posterior end is posterior and outward, so it stretches the zonular ligament and lens become flattened or thin. But when ciliarus muscle contract, posterior end move forward and inward, so suspensory ligament become slack, they become loose. When suspensory ligament become loose, then lens capsule is not under tension and the lens become globular, right? So actually, when any object from far come near to us, right, we need a lens with more dioptric power or more focal power. So when a far object comes near, I undergo a process called accommodation. And one of the part of accommodation is that ciliarus should contract and reduce the tension on the zonular or suspensory ligament, so that lens become more globular, so that it can focus better on the near object. Am I clear?
Yes, sir.
Now and you will see the near object more clearly. Now our parasympathetic fibers, they, as I told you previously in the lecture, they reach to the ciliary ganglion, and from the ciliary ganglion, which nerves are going? Short ciliary nerves, and short ciliary nerve take these parasympathetic fibers, and these parasympathetic fibers are supplied to ciliaris, and parasympathetic fibers are also supplied to constrictor pupillae through the short ciliary nerves. So we can say these parasympathetic, but they do not supply the dilator pupillae. Supply to dilator pupillae is a function of sympathetic nervous system. Now, so we can say the visceromotor fibers of oculomotor nerve or parasympathetic fibers or general visceral efferent fibers, they actually supply the constrictor pupillae and also ciliaris muscle. Is that right? Now, if these visceromotor fibers are damaged, what will happen? Do you think constrictor pupillae will contract well? No. Normally, the normal size of pupil is maintained by a balance of the tone between the constrictor pupillae and the dilator pupillae. So when visceromotor fibers, parasympathetic fibers fail to the eyeball, they are damaged, then constrictor pupillae does not have any appropriate tone, so it becomes loose, and there is unopposed action of dilator pupillae which open the pupil pathologically, and this pathologically dilated pupil is called mydriasis, or we call it blown pupil. So this is what you can see here. Pupil size is small, here pupil size is large. If this is large, it means not only extraocular, not only somatomotor fibers are damaged, but here you can say parasympathetic fibers are also damaged. Am I clear to everyone? Yes. Sure? Okay. Second thing, what will happen? Now, not only pupil will be dilated, right? With that, there will be paralysis of ciliaris muscle. When ciliaris muscle become paralyzed, this condition is called cycloplegia. What is it called? Cycloplegia. Cycloplegia. So when ciliaris muscle become paralyzed, right? Do you think when objects from far become near, it will contract? And can lens accommodate properly its so what will happen, that many objects which are near, they will look blurred. They will look blurred. So what will happen? Number one, there will be dilated pupil, dilated and fixed pupil. This pupil will not respond to the light. Is that a light response? And this light reflex pathway and accommodation reflex pathway I've already discussed in other videos related with the second cranial nerve. Anyway, so there will be dilated and fixed pupil or dilated and poorly reactive pupil, and with that there may be cycloplegia. Remember, when pupil become dilated, when there is excessive light, if there is not too much ptosis, normally what happens, there is too much ptosis, right? But if there is partial ptosis and still pupil is there, and in this situation, when you see when there is a dilated pupil, in bright light there is excessive light going in the eye, and that may produce sort of what? Glaring, uncomfortable feeling, because in normal person, in function, if your oculomotor nerves are properly functioning in relatively bright light, both people will constrict and control the input of light. But here, because it cannot constrict, so such patient, if it is not already covering it completely, right, then there will be excessive light going on, and we say there is irritating glare of light. What is that? There is irritating glaring of light, glare of light, right? And third thing, when there is cycloplegia, a person cannot focus well on objects, right, according to their distance, and they may lead to blurring of vision. So blurring of vision. Now, dilated fixed pupil with glare of light and blurring of vision through this eye, right? If these features are present, it means that there is failure of parasympathetic fibers. There is failure of parasympathetic fiber. If there is failure of parasympathetic fiber only, then this is called internal ophthalmoplegia. What is it called? Internal ophthalmoplegia. Now, what we can say that related with the third cranial nerve, there can be external ophthalmoplegia when there is partial ptosis and eye looks down and out. And external ophthalmoplegia is due to somatomotor fibers failure. And if the damage is to the parasympathetic fibers, then there is internal ophthalmoplegia in which pupil is pathologically dilated and there is blurring of vision and glare of the light.
Yes.
Am I clear?
That's right.
So now onward, what we discuss. Some basic symptoms we have discussed presentation. The patient who has third nerve palsy, either he can have, if only somatomotor fibers are damaged, he will have. No, if there's somatomotor fibers, then he will have external ophthalmoplegia, right? Eye looking down and out with partial ptosis. And if patient has parasympathetic fibers damage, interruption, then there will be internal ophthalmoplegia with fixed dilated pupil with glare of light and blurring of vision. Am I clear? Done. Now we come to that, we just talked about what happened to eye when there is damage to the third cranial nerve. But now we'll talk about why there is damage to the third cranial nerve. What are the causes of damage to the third cranial nerve? So let's go for that now. So let's go back and we talk about step by step damage to the third cranial nerve. Now look, we will not try to memorize in a haphazard manner. We'll go step by step, right? Start with the midbrain again. What can damage the third cranial nerve in the midbrain, right? So let me make the midbrain here. Okay. First of all, I will tell you, you remember that there was an artery going from here and this was going into posterior. What is this branches? Posterior cerebral, yes, artery, right? And here there was artery which was very good, posterior. Oh yes, very good, superior cerebellar artery, right? And we'll talk about other later. Now, of course, it is going to other side as well. And there's interior, posterior communicating also, right? They're posterior communicating. We'll talk about that later. Now, first of all, what kind of damage can occur in the, this is your cerebral aqueduct. Here is your substantia nigra, yes, substantia nigra. This is crus cerebri, right? Here the fibers are descending pathways, corticospinal fiber, corticobulbar fibers, pontine fibers. They are going from the cerebral cortex downward. These fibers are going down. And here was your friend, which nucleus? Red nucleus, right? And here was your lemniscal system, you know, ascending pathways. Medial longitudinal fasciculus is here, but we will not talk about that. This is medial lemniscus and other structure, and this is superior colliculi, and there are many others. But you remember, here was our nucleus of oculomotor, and fibers are moving forward, passing through red nucleus, medial part of this, and then from here they will move exit, right? Exit will make it later, and with that, of course, you know that there was which nucleus? A Dinger Westphal, and its fibers were also going with it, right? Am I clear?
Yes.
Now, what can damage these this nucleus of the third nerve, nuclear complex of third nerve, or the fibers of the third nerve while they are traversing within the midbrain, right? What are the damages here? Of course, some damage can be very simple. For example, if these blood vessels which are supplying here, right, they may undergo rupture, there is hemorrhage, or blood vessel is blocked because from here the vessels are going in. You understand it? So these blood vessels, either they rupture. If they rupture, that will lead to hemorrhage, right? Or some blood vessel block, and depending part of the midbrain undergo infarction. An infarcted area also include the nuclear complex or the fibers of the third cranial nerve passing through. Then we can say the other cause can be infarction. Infarction means that due to ischemia, right, some part of the midbrain here undergoes necrosis or death, right? Or there can be tumor, yes, if there is some tumor, or there can be some infection, right? And that infection may produce a small abscess, a pocket of pus, right? Or sometimes the fibers which are passing through this area, they undergo a process called demyelination. When these fibers undergo demyelination, then there is a immunological immune mediated damage to the myelin system of the, that is called multiple sclerosis. So there may be demyelinating conditions like multiple sclerosis. So these are few examples that how a damage can occur to third cranial nerve while third cranial nerve fibers, this is called fascicular portion or its nuclear portion within the midbrain. There can be hemorrhage, there can be infarction, there can be tumor, there can be abscess, there can be demyelinating condition. Is that right? Let's suppose there is infarction. Now is the point to understand, right? Focus, really focus. Forget about your boyfriends, girlfriends, and all other. I'm not going to talk about animals, but all animals you like or all fairy tales. Forget about everything, right? Just focus on. Actually, when damage occurs to the midbrain, of course, it is not necessary that damage may be limited only to third cranial nerve. Some other structure may also be damaged. For example, if infarction is like this. Let's suppose if infarction is like this area is infarcted, right? Blood vessels which are going over here, either they are blocked or they rupture. There is hemorrhage or infarction in this area, right? This area was crus cerebri, through which corticospinal and corticonuclear fibers were going down, through which the motor fibers were going down. Now those motor fibers which are going down, descending, they are damaged. Along with that, what is damage? Third cranial nerve. Is that right? Now let me draw this diagram here. That let's suppose here is your midbrain, pons, medulla, right? This is lower motor neurons going to the muscles. Now you see that what really happens, the corticospinal fiber, right? They come over here, they are passing through midbrain, and from here they decussate and cross. Is that right? In the same way, fiber from here, they are